Welcome. This is a re-recording of the Nevada Cancer Coalition Cancer Education Lunch and Learn, originally hosted on Wednesday, February 28th. Due to technology issues, we were unable to record that webinar live, and we are recording only the two speaker portions with Dr. Chen and Dr. Gewelber today. We will go ahead and cover the content both on prevention of HPV focus and early detection of HPV-related cancers under this webinar series. Thank you, Dr. Chen and Dr. Gewelber, for being here today. And I am turning over the screen sharing to you, Dr. Chen.
Great. Let's see. All right. Well, thank you, Lily, for that lovely introduction. I am Alice Chen. I am a pediatric dentist, board certified by the American Board of Pediatric Dentistry. I'm also a fellow of the American Academy of Pediatric Dentistry. Give me 1 second. All right. And I have practiced in Nevada for the past 16 years. And for the past 2 years, I have served as an associate professor in Roseman University's 2 AEGD clinics here in Las Vegas. I went to dental school in the early 2000s and finished my residency in 2007. At that time, the first HPV vaccine was just starting to roll out, and the conversation was 100% about cervical cancer. There was also a lot of conversation about identifying patients who would actually benefit from the vaccine. So back then, we were supposed to identify them by sexual practices and number of sexual partners. So for a very long time, my own knowledge on this topic, probably like many of you in the audience, was sort of stuck in that era. In the recent years, fortunately, I have been learning so much more. So I am very excited to be here today to share with everyone the new changes that have taken place. Today, HPV is no longer just about cancer in our reproductive areas. We, as dental professionals, have an ethical obligation to be involved because 20% of oral cancer is caused by HPV, and 70% of oropharyngeal cancer is caused by HPV. This chart is taken from CDC's data between 2016 to 2020. The column on the left shows the number of cases for each area where HPV can induce cancer. Now, obviously, not all cases of cancer is caused by HPV. So the middle column shows the percentage of cases for each type of cancer that is HPV associated. And the last column on the right shows the estimated number of cases for each type of cancer that is actually caused by HPV. So when we compare the top row to the bottom row, that is comparing cervical cancer to oropharyngeal cancer, we can see that while HPV is responsible for 10,000 cases of cervical cancer, which is a huge number already, for oropharyngeal cancer, that number is actually even higher, and that is 14,000 cases per year in the United States. In 2014, a big study was published, and it was found that 84% of people will acquire HPV infection at some point in their lifetime. And for most of these patients, this will be completely asymptomatic. 80% of men and women will have HPV by age 45. Now, as part of the study, adults with no sex partners were excluded. With the last bullet point, I wanted to just add a note that while I was preparing for this presentation, I started thinking about our developmental and intellectually disabled community, and that parents and caretakers for these individuals might be somewhat resistant to receiving the HPV vaccine, just because they might assume that there will be no sexual partners in these patients' lives. What I found out, and this is really, really sad and heartbreaking, is that an estimated 90% of people with intellectual disability or developmental delay will experience at least one episode of sexual assault in their lives. So that's 90%. This community, please, is not to be forgotten when we try to spread our vaccination message. Okay. And in the previous slide, we talked about the fact that 84% of everyone will get HPV at some point in their lives. So guess what that number was 20 years ago? It was actually, I'm sorry about this talk. It was actually only 26%. Now we know the epidemiology of the human papillomavirus has changed drastically in the past few decades. This is most likely because our own sexual behaviors have changed over time. I'm sure everybody has heard of Ashley Madison. This is a website for married adults who are looking for no strings attached extramarital experiences. There was a famous data breach in 2015, but even today, Ashley Madison has 70 million global subscribers. And all those people want the peach, but not the ring. So that's what the adults are doing in our country. Now, let's take a look at what American teens and tweens are watching. So my daughter just turned 13 last month. This were 4 of the shows that she and all her friends watched on Netflix last year when they were 12 years old. These are actually screenshots from scenes of these shows. So really, really pretty racy images here. Fortunately, most people who acquire HPV do not actually end up with cancer. Those of us who are logging in today, most of us have a science background. And especially for those of us who treat patients, we like to practice what we call evidence-based medicine. So identifying risk factors for cancer is an area that's very important to think about. With oropharyngeal cancer, some of the known risk factors are previous infections, genetics, age, chemical exposure, such as tobacco and alcohol, and lifestyle. But unfortunately, the bottom line is that based on today's science and what we know, there is no reliable way of predicting who will end up with cancer and who will not. So we used to target only girls and women when it comes to vaccination. That was when we were primarily worried about cervical cancer. Dr. Neil Grossman, who is the director of head and neck surgery at MD Anderson, he found that today, oropharyngeal cancer in men are 4 times more likely than in women. They used to see mostly smokers. Now they see mostly non-smokers, and their throat cancers are almost uniformly HPV-related. And that HPV-related throat cancer patients are now non-smoking, white, heterosexual males, usually in their 50s and 60s. There are different ways to prevent HPV, including, and this is from the CDC website, number 1, to avoid tobacco use and to avoid alcohol use. CDC wants us to minimize number of sexual partners and to avoid oral sex, which I think realistically might be difficult to achieve. CDC also recommends using condoms and dental dams during oral sex, which is an even more difficult message to push towards people. And the last 2 bullet points are what we're going to focus with our mission today with Nevada Cancer Coalition, that HPV vaccination needs to start at age 9 because younger patients produce a stronger immune response, and to perform regular exams to facilitate early detection. So I thought it was interesting that back then, there was really not too much talks about oropharyngeal cancer. It was still mostly, the conversation surrounded mostly our reproductive areas. HPV vaccine was first developed in Australia. It was introduced in 2006 to patients in our country, targeting mostly teens and young adult women. In 2009, the vaccine received approval for boys and young men, preventing penile and anal cancer. When given under age 15, the recommendation is 2 doses. After someone turns 15, then they will need 3 doses. to be fully vaccinated. Here are some data associated with Nevada. So how are we doing in our state? We have about 60% of teens receiving all 3 doses of the vaccine, and we rank number 37 in the nation, which is a lot better than our public school ranking. But I believe that with all of us working together, we can do much better than this. Our problem with vaccination rate in Nevada is twofold. The first problem is, unfortunately, with ourselves. In 2020, so this is only a few years ago, University of Nevada at Reno published a study where they surveyed their medical students, physicians, assistant students, graduate students in public health, and family medicine residents. What they found, among other things, is that only 30% of these students are aware of the strong connection between HPV and oropharyngeal cancer. So we just need to do a much better job in educating ourselves. And for our dental colleagues, we're really not doing that much better either. The American Academy of Pediatric Dentistry found that even though the majority of pediatric dental program directors believe that they should be discussing HPV with their patients, only 25% of these same directors actually include HPV vaccine in their residence curriculum. So for all of us here today, we just need to become front runners to beat these sad statistics. The second deterrent are, of course, the parents who ultimately have the right to decide whether or not to vaccinate their children. Vaccine hesitancy usually comes from either medical mistrust or misinformation. So how can we as dental professionals be successful drivers in increasing HPV vaccination? It turns out that we're actually really just naturally good propagators in this mission. Number one, we see our patients more often than they see their own doctors. Our patients, they already like us, they trust us, and they trust us in caring for their kids. While we perform intra and extraoral exams, it's also very easy to tell our patients why we're doing these exams and at the same time bring up the subject of vaccination. These conversations, when practiced and rehearsed, can flow very naturally because we're already talking to our patients about prevention and wellness. Even with proper training and knowledge, it can be hard to add one more subject into our already well-rehearsed patient routine. For me personally, forgetting to bring it up has been the biggest struggle and the biggest challenge. What eventually helped me was to have a visual physical flyer in each operatory to remind myself. In fact, Nevada Cancer Coalition has a very nice toolkit that is free to all Nevada providers. This toolkit comes with a very nice folder containing beautifully printed and catchy flyers that you can put on the wall or in a flyer stand on the counter. These flyers will not only help with patient education, but also serve as physical reminders for us to include it in our conversations with our patients. We probably have all heard this phrase that a provider recommendation is the strongest predictor of HPV vaccination. This is nothing new. But in 2018, there was a small study that was done in Dallas. What was very interesting about this study was that they categorized providers as being either acquiescent or persistent. Acquiescent providers are those of us that give patients the information. Once patients show any kind of hesitancy, we say something along the lines of, okay, well, I'll let you think about this and we can talk about it next time. And I have to admit, I used to be an acquiescent provider. I wanted to be nice. I wanted to be relatable. I didn't want to be pushy or aggressive. But what they found in this Dallas study was that of all the families who had acquiescent providers, none of them, 0%, decided to get vaccinated. So again, that's pretty sad. The other category of provider is the persistent provider. Persistent providers in this study were able to convince 17 out of 18 hesitant families to get vaccinated on the same day. So being a persistent provider is what we should aim to model after. And we're going to talk very specifically about what this may look like, which I can assure everyone here, it does not involve being mean, pushy, or aggressive. There are very practical and effective strategies to communicate with families who are hesitant. And in the past 2 years, since I have incorporated this conversation into my routine, I sort of developed a script that I will share with our audience today. This is usually something that I bring up after we're done with all the dental and the teeth stuff. And it goes like this, and you can create your own version, whatever suits your own style. So this is for my patient, 13-year-old Benny. And what I will say is, all right, Mom, one last thing we need to talk about today is the fact that Benny now is at an age where we need to think about HPV vaccine. I know it seems strange that this is being brought up by me as your dentist, but we are extremely concerned these days about oropharyngeal cancer, which is caused by HPV 80% of the time. We know that almost all adults will be exposed to HPV at some point, but our current science doesn't have a good way of predicting who will end up with cancer and who will not. So getting the vaccine is the best way to prevent throat cancer. At your next well-check visit with Benny, please bring this up with your pediatrician and get vaccinated. I have to say, most parents are very receptive and enthusiastic about getting vaccinated. And of course, sometimes parents can be hesitant. For hesitant parents, we want to utilize effective communication strategies. So first, we want to assure our parents that they're not the only ones who are hesitant, and acknowledge their uncertainty and anxiety. We should also compliment their efforts on being willing to hear more about this topic and reiterate that our role is to share and not to judge. Instead of asking a parent why he or she doesn't want her child to receive the vaccine, ask more specific questions such as, are you worried about the safety of the vaccine, or you just don't think your child will benefit much from the vaccine? Once the cause of hesitancy is identified, ask for permission to share more information. You can say something like, these are very valid concerns, and thank you for letting me know about them. I actually just took a class on HPV vaccine, and I would love to share more information with you that specifically answers some of these questions. As with all conversations relating to prevention, education, and advocacy, the more we practice having these conversations, the more comfortable, natural, and fluid they will become. And I have 100% confidence that all of us here can start practicing this week, if not this afternoon. So for the last slide of my portion today, I want to bring up these earlier screenshots from the shows. In this slide, I added the ages of the characters when they were engaging in these sex acts on screen. So 16 and 17-year-olds who are showing our teens and tweens, how to get steamy with their boyfriends and girlfriends on TV. Just some food for thought. I really appreciate your time, and thank you so much for listening. And I will turn the screen over to Dr. Gewelber.
Thank you, Dr. Chen, for that amazing overview, and just introducing Dr. Gewelber to speak on early detection in the dental community. Thank you so much.
Okay, is it looking right? I'm making sure I'm getting all set up
It
right.
looks fantastic. It's good.
Okay, perfect. Thank you. All right. Well, hello everybody. My name's Civon Gewelber. I am a graduate from University of the Pacific School of Dentistry in 2012, and then I did a general practice residency after that, and have gotten a lot of experience with hospital dentistry and working with patients with intellectual and developmental disabilities. But now I'm here at Roseman University in the AEGD program and have been happy to come into this topic of oropharyngeal cancer awareness and prevention, learning more about the HPV vaccine, and sharing some of this information with you, dental providers who need to also recognize our important role in this process in educating patients and helping with early detection. So just before we get too far into this dentalcare.com CE is really excellent. You can go through it at your own pace, and it goes through every detail about how to perform a very good and very thorough intraoral and extraoral exam. We learn this in dental school and in hygiene school, but in private practice, at least in my experience, we are finding ourselves not having as much time to be as thorough and detailed as we should be and could be. So I review this course once in a while to stay on top of my it and make sure that I'm not cutting any corners or skipping over anything that could be important. It literally could be the difference between life and death for a patient someday. So it's important that we do this correctly every time. With that, I have this kind of clock set up here where I go through each single item as a deliberate observation. So every time when you look at something, it must be deliberate and intentional, where you're specifically looking and judging whether something looks normal or abnormal, or is it a variation of normal? Is it symmetric? Does it look the same on both sides? Are there symptoms associated with it? How long has it been there? These are all questions and things that, as you do this for every single patient, every time you look in someone's mouth, whether you're there for a comprehensive exam for a new patient or for periodic exam or for filling, we should be quickly but thoroughly looking through every single one of these things. I start when I say hello to a patient, looking at their skin, their face, look in their eyes. I'll ask about TMJ symptoms and check if they have deviations when they open and close. Ask them to swallow and see if they have difficulty swallowing or if there's any pain during swallowing. Checking lymph nodes can be difficult for any provider, but if there's tenderness in the neck and throat when trying to palpate for lymph nodes, that could also be an early sign of a potential problem where we would want to refer to their physician or to an ear, nose, and throat doctor to do a more thorough evaluation. I look at lips and make sure there's no breaks in the vermilion border. Depending on if a patient has very dry or unusually discolored, little spots of discolorations, I ask if they wear sunscreen, if they have a dermatologist. If they don't, then I suggest that they go have a checkup with a dermatologist periodically, because skin cancers can look like nothing until there's something really important. And even though I'm not a dermatologist, I still remind people of the importance of other specialties and other early detection and screening procedures that can be done very quickly and efficiently by the appropriate individual, so the appropriate doctor. Then looking inside the mouth, I check on the buccal mucosa, which is the inside of the cheeks. I look at salivary gland function for the parotid glands. Looking at the Mallampati score, so that's basically like how clear is the airway and how easily can I evaluate the oropharynx and how can I see past their tongue. I look at their tonsils, ask if they've ever had them removed if I can't see them. I look at the oropharynx, as much of it as I can see, but there are limitations to how far we can see, even if somebody, has a wide open airway and very easy to visualize. Depending on risk factors, I'll come back to that actually. Back to the hard palate, soft palate, tongue, floor of the mouth. So the lateral borders of the tongue and the floor of the mouth are very important areas to evaluate, because those are some of the more common areas to find dysplasias for other oral cancers. I look at the quality and consistency of the saliva, which is a risk factor for even dental caries, but saliva can tell you information about the patient's oral health. I look at the ridges, the gingiva, and of course the teeth and the radiographs. But as a dentist, it's really easy just to look at the x-rays and go straight to the teeth. So that's why it's last on my list. I start with everything else so that I don't accidentally skip it and don't remember to come back to it. Medical history is important. Also, family history for cancers. The medical history includes medications, head and neck radiation, things like that, like basically a history of cancers in other areas, dental history, social history, smoking, tobacco use, habits, all those things. So we spent a lot of time on this slide, but again, it's nice to have a list and an order that I go over things so that we make sure we don't forget anything. So then quickly here, that's like I mentioned, it starts with a hello. We can see things on the patient's face and skin, and it helps the patient build trust with us so that they know we're paying attention and they know that we care and that we're observing things and that we're educating them So here's the area that we're all more familiar with. When you ask a patient to say, ah, can you see everything all the way back? And then you see that this tonsil is asymmetrically enlarged. So oral surgeon, oral pathologist, excuse me, Dr. Ashley Clark mentioned in the last lecture that I watched with her, when tonsils are asymmetric, always refer. So if nothing else, if you see an asymmetric tonsil, always refer to an oral surgeon for evaluation, to their ear, nose, and throat specialist if they have one established already, or to an oral pathologist if there is one convenient, if you know of one in your area. There's an article from the Journal of, from JAMA, I'm sorry. It says significant asymmetry of the tonsils, especially if there's rapid enlargement, may also portend a serious underlying condition such as a lymphoma or other lipid storage disease or Langerhans cell histocytosis. So basically, if there's an asymmetry, go ahead and refer. So when some people say ah, it's not quite as clear. The tongue gets in the way. They have a gag reflex. It's difficult to depress the tongue. You can't. The oropharynx is not as clear. There's a shadow. I mean, you just can't do a good evaluation. I talk to the patient about risk factors because if they haven't reported risk factors, I don't assume that they don't have them. So I tell them what the risk factors are, and then they can, in their own head, go through and check the boxes and see if maybe they do have those risk factors or not. So if there are risk factors, I encourage them to go get a referral to an ear, nose, and throat specialist so that they can have a little camera put down their nose and check out their whole throat in more detail, and learn more about the early detection process. Additionally, I also do screening for sleep apnea and do referrals to their physician for sleep studies as well, because sleep apnea has other detrimental systemic risks for people. So for some of the risk factors, just to throw them out there in case somebody doesn't know, we have family history and genetics, tobacco usage, alcohol usage, and then HPV infection. So Dr. Chen did mention some of these, and I just wanted to point out, additionally, the American Cancer Society had additional risk factors like obesity, age, poor nutrition, and people who specifically drink and smoke rather than just one or the other. So drinking and smoking combined leaves people at an even greater risk than those who just do one or the other. One tidbit they mention is for HPV-associated oropharyngeal cancers, they tend to have a better prognosis than people who get non-HPV-associated cancers, but except for people who smoke. So if people smoke, then their outcomes can be affected negatively. So here's a quick little diagram, just if anyone's not familiar with the Mallampati score that I mentioned before. So it's a kind of an evaluation of how clear the airway is, if they have a long, soft palate, if their tongue is tall and blocking your view. And then this is a Friedman score, which is very similar to the Brodsky scoring system, if anyone's heard of that. The difference is Brodsky includes people who don't have tonsils and people whose tonsils are barely visible. So Brodsky 1 is the same as Friedman 0 or Friedman 1. Let's see. So I mentioned for early detection, the easier you can see back there, the better, the more likely you're going to catch something sooner than later. So I'll go through a couple of examples of patients that I've looked in their mouth and was surprised by what I saw, and also surprised that the patient had been to many oral healthcare providers in the past and was never informed that they might have something unusual happening in their throat. So this is a 10-year-old boy. He had kissing tonsils, which means that basically when he said ah, his tonsils from each direction practically touched. It's an obstruction in the airway. This little thing in the back of his throat was also popping up, and I had never seen that before. It turns out that's his epiglottis, which is there to help protect his airway, but it was sticking up, which I thought was definitely strange. This patient also had very poorly controlled asthma, and along with the large tonsils and the constricted airway, he was also very overweight. And all of these things combined led me to insist to his parent that they take him to an ENT ASAP. So they took me seriously because the look on my face must have definitely showed how serious I thought this condition was. And he had his tonsils removed. He was made to lose weight, and they report that he is sleeping better, feeling better. His asthma is under control. He's snoring less. And they thanked me so much for telling them that they had no idea. And to me, it was so obvious, but to most people, they just didn't take the time to look. And I think if we all take the time to look, we're gonna be able to help people like this young man. This is another case. This is a young lady with Down syndrome that I treated at the hospital, and she was almost cooperative for treatment without sedation, but I couldn't get bite wings on her posterior teeth. I knew she had a couple of cavities on her front teeth, and I thought, I better just be careful. We'll take her to the hospital one time, and then we'll work on prevention of oral diseases and prevention of caries in the future so that we don't have to take her back to the hospital again anytime soon. While she was sedated, the anesthesiologist put in the nasal intubation, and then I went to start a throat pack, and I discovered this very interesting little growth hanging off of a stalk off of her uvula. And there was no way anybody was going to see that unless she had been asleep for that evaluation. Not to get into too many details, but this little stalk had a very distinct blood vessel, so I was worried about removing it myself. And we called an ENT to come down, and they removed it and took care of the biopsy and follow-up and reporting that was required for this. And this just kind of goes back to what Dr. Chen was talking about, that individuals with intellectual and developmental disabilities are still at risk for contracting HPV infections. And that's just the reality of the situation. So I will be including the conversation about HPV vaccination with more of the adults that I treat that have risk factors that are not obvious, basically. So when this patient woke up and I informed the mother of the growth and that we removed it, she said, "Oh, that must be why she's coughing and gagging a lot." So it's really important that we provide that level of attention to everybody, even if they're not exactly asking for it. So in general, HPV infections can turn into something. They can turn into nothing, or they can turn into something really small, like this little wart on the gingiva. This type of lesion is often not precancerous, but it is a great segue into starting a conversation with patients about their risk factors. And even if you see something like this on an adult patient who may or may not by themselves, sorry, I hope that's not too loud, who may or may not themselves be eligible for the vaccine because of the lack of expectation of benefit for them, they may have family members with children or grandchildren or nieces and nephews who would benefit from the vaccine. So educating everybody, even if they personally would not benefit from the vaccine, is very important. So coming up on my last two slides, and I thank you for your time, I treat mostly adult patients, and talking to adults about HPV is a new thing for me. So like Dr. Chen, I've looked at different strategies that other providers have and other organizations like that we've talked about have put out there to help us talk to patients about HPV. And one thing that I find makes it really easy to get the conversation started is talking about my own personal experience. So I was vaccinated as an adult, and my physician told me that it might be too late. I might be too old to have, a benefit from the vaccine. And I know my personal history. I didn't have a lot of partners, but I was concerned about, even if it didn't have any benefit, it would still probably not hurt me. So I just wanted to be better safe than sorry. So I tell patients that I vaccinated myself because the consequences of not being vaccinated and winning that lottery to be one of the few people that develop oropharyngeal cancers is not a risk that I wanted to take if I didn't have to. So it's one of the things I talk about. Most HPV infections do turn into nothing, but you don't want to be that one or two, out of however many that are going to develop a problem. This is the exact guidelines for HPV vaccination for adults. With children, it's the strong recommendation to do it, especially at the right age, so that they can have the best immune response and only 2 shots instead of 3. But with adults, it's more of a conversation with their primary care doctor to decide what the expectation of benefit is going to be. So instead of just reading you all of these bullet points, just in general, because it is a shared decision with your primary care doctor, many of the things that Dr. Chen mentioned is your risk of acquiring a new infection based on sexual practices, and also previous infection. So knowing if you've had a previous infection, but there are many strains of HPV and several that can lead to cancer. So even if someone's had one, perhaps the vaccine will help protect them from a different one. So I appreciate your time today, and thank you very much for letting me share this information with you. Here's my reference slide, which if that's helpful, and then you can always reach out to us, and we would be happy to answer questions via email or phone at your convenience. So thank you very much.
So that concludes the re-recording of the HPV-related cancer prevention for dental professionals with Dr. Alice Chen and Dr. Civon Gewelber. Thank you both for your time in not just doing this once, but twice. And also a thank you to Todd Landaburu, who shared his story as a person still going through treatment, still working through that survivor status and the impact of HPV-related cancers, oropharyngeal-related cancers, and the power of non-traditional providers in being part of that prevention and early detection team. So just want to say thank you to this entire panel. If any audience is interested in asking questions, please reach out to myself at lily@nevadacancercoalition.org, and I will connect you with who you need to be connected with. Or if you're interested in one of the toolkits that Dr. Chen referred to, you can visit our website for a downloadable version, or I'd be happy to mail you a hard copy as well.